Good morning and welcome to Common Part B Colorectal Surgery Rejections and Denials. I am Mary Mucko. I'm a member of the WPS Provider Outreach and Education, or PO team, and I'll be your presenter today. I'm joined by my teammate, Jennifer Boniface, who will assist with some behind-the-scenes help. This webinar is for those people who are wishing to learn about the most common rejections for colorectal surgery claims submitted to WPS. Now, CMS does require the MACs to include this kind of education in order to prevent future claim rejections and denials, and just as advertised, the information that I'm going to be presenting in this webinar today is based on actual claims data. I do need to cover a little bit of housekeeping with you before we get into the presentation. This presentation is available to download from our live events webpage. The page address is in the chat. You may take time now to download it if you haven't already done so. We will record this session, and barring technical difficulties, we'll post the recording to our Encore Presentations webpage, where it will remain about 60 to 90 days. The recording will also post to our YouTube channel, where it will remain as long as the information remains current or we otherwise determine that we need to remove it. Now, if you have questions, please put them into the chat. I will answer questions as time permits. We have a lot of information to cover, but if I don't get to your questions during today's live session, I will tell you later how you can send those questions to me. If you have a question on a specific claim that is in processing, one that is already denied, or otherwise sent to Medicare, I cannot answer those questions relating to that specific claim. Provider outreach and education staff does not have access to claim history, whereas our customer service staff does, and they'll be happy to help you. Now, when you're registered, I did get a lot of questions or questions that you indicated that you would like me to answer during today's session. But this session today really does focus on data for the most common rejections and denials. And I did send an email out to everyone a little bit earlier today explaining what specifically we would be covering today. We include this disclaimer in all our events. This presentation is for educational purposes only, and I did make every effort to verify that the information that I'm going to provide is current and correct, but it is subject to change. It is on the CMS website that you will find the Medicare rules that determine final coverage. These laws, regulations, and rules will always prevail. CMS prohibits recording this webinar for profit-making purposes. We ask that you do not record this presentation. We will create an encore of this presentation, and you may use that for future reference. Now, here's that agenda that I talked about. This is what I advertised that I would specifically talk about today during this 60-minute webinar. This is exactly what the advertisement read. Our goal is to share with you the most common rejections and denials for colorectal surgery claims. I'm going to define rejections and denials, reveal the reasons for rejections and denials based on the data that I pulled and analyzed, and I'm going to discuss how to fix and avoid these and provide you with many resources. Now, this is a lot of information to cover in 60 minutes. I'll be moving very quickly through this slide deck, and I may ask you to review some of the information following this live webinar. This information that I'm presenting today has a lot of helpful resources, because if you look right there at bullet 3 on this agenda slide, I told you that I'm going to discuss how to fix and avoid both common rejections and denials, and you'll need some of those resources to come back to if you don't remember everything that I'm going to talk about today. Now, some of the topics that you said you wanted to learn about today had to do with screening versus diagnostic colonoscopies. I saw some comments out there asking for information on what kind of documentation is needed. Also some very specific coding questions, and CMS actually prohibits us from giving coding advice, so I can't tell you how to code something, but if you need information that we're not covering today, anything that's not on this agenda, give our customer service staff a call and they'll be happy to assist you. Another thing you can do, we do have CMS requires us to do this. We have a brief survey that we're going to ask you to complete at the end of this presentation today. If the topic that you wanted to hear about isn't one that I'm talking about today, go ahead and place that topic on that survey. We take all of the information and suggestions from that survey, and we consider those topics for future education, those that are mentioned on that survey. So do put that on that survey when you complete it. Now, in order for me to discuss rejections and denials, I do need to provide a bit of information about the claim process, but before doing so, I want to talk about this CPT copyright notice. This is the American Medical Association's copyright notice for CPT codes, descriptions, and even other data. Now, I've included this copyright notice in my presentation materials, and your continued participation in this presentation infers that you agree to the terms of the copyright notice. Now, here's where we're going to dive into that claim process so that you really understand rejections and denials. Now, based on a law that requires that most providers submit claims electronically, reports generate to confirm claim receipt here at the MAC, or the Medicare Administrative Contractor, and they report even more specific information about the data requirements. Now, one of these reports is the 276-277 report. The Medicare 276-277 companion guide that's prepared by our electronic data interchange or EDI staff helps submitters understand the claim requirements and know when they need to correct or resubmit the claim. Claims that move past these pre-pass edits will generate a remittance advice. We often call this the remit for short. Some people call it the RA, and some people even call it the notice. Now, there are two different formats: the electronic remittance advice, or the ERA, and the standard paper remittance, or the SPR. Now, with few exceptions, most providers are going to receive the electronic remittance advice. The RA provides important information to the provider. For adjudicated claims, you can find information about adjustments and denials, even missing items, refunds, and sometimes even offsets. When looking at a remit, you will find various reason and remark codes. These are typically in an alphanumeric format. When claims pay differently than billed, a claim adjustment reason code appears on that remittance advice. Sometimes a remittance advice remark code will also appear. These expand on details described by a reason code to provide more details about the adjustment made to that claim. Another type of code on the remittance advice is a group code. Group codes assign financial liability for any unpaid balance on the claim. Now, a CO stands for contractual obligation, and it means the provider is liable and can't bill the patient. And a PR code, group code that is, means that the patient is financially responsible. WPS hears a lot of comments about these codes. Providers often state that these codes are too cryptic or that they contain certain outdated acronyms or information. Now, while we'd really like to help, there is another contractor, not WPS, who maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on their website where you can find contact information should you wish to suggest a change to the code lists, including those code explanations. This slide shows you a side-by-side comparison of a rejected claim versus a denied claim, and they really are two very, very different things. Oftentimes, even at WPS, when I'm talking with people from other departments or even within my own department, people use these interchangeably, and we really should not, because they are really truly two different things. A rejected claim is unprocessable. We can't process it. It's never adjudicated. It's actually returned to the provider on the front end. Remittance advice does generate, but it states on there, it provides some reason and remark codes. And here on this slide, it says MA130 and CO15. You need to make a change to that. That should be a CO16. Those are the codes that are going to, those reason and remark codes that are going to print out, and group code, that are going to print out on that remittance advice for a rejected claim. Rejected claims are rejected because something's missing or incorrect, invalid. Something just doesn't make sense. It's illogical. Because of this, they're actually just returned to you on the front end. What you need to do is fix it and resubmit it. Because they're never adjudicated, there are no appeal rights. You need to fix it, resubmit that service. The patient's not liable for any charges for a rejected claim. A denied claim, on the other hand, is actually adjudicated. Sometimes we deny claims for many different reasons. It could be a law or a statutory requirement. Sometimes we deny claims because it doesn't meet Medicare's medical necessity rules and guidelines. This would include any frequency parameters. Another type of denial is an eligibility denial. It could be that the patient is not eligible, or it could be that the provider's not eligible. For these, you'll find an MA01 code. Typically, now let me say that with few exceptions, a denied claim is going to show that MA01 on the remittance advice, and what that means is that you have the right to an appeal. Patient liability is determined for denied services. Now, depending on whether your claim is rejected or denied, you're going to need either to correct or appeal the claim. And here are some potential actions to choose from. After reviewing that remittance advice, you're going to need to choose for an unprocessable claim, one that's rejected. You'll need to fix the error and resubmit the claim to Medicare. Now, if the claim or claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit that service. You might use the clerical error reopening or SIR process to fix clerical errors, and CMS defines clerical errors as human or mechanical errors on the part of the party or the contractor. Another action to consider is an appeal. The remittance advice will provide appeal rights if there are appeal rights. Most denied services do have appeal rights. I'll discuss appeals a little bit later in this webinar. Now, registered users can use our SecureNet Access portal. We call it SNAP. That's that transactional side of our transactional portal side of our website, that secure side. If you're a registered user, you can use it to render or request a clerical error reopening or to request an appeal. Now, these self-service tools really do offer the most efficiencies. And our portal user manual provides illustrations and step-by-step instructions on how to use these portal features. For claim denials, most often you can request an appeal, and the purpose of the appeal process is to ensure the correct adjudication of claims. Physicians and suppliers and beneficiaries have the right to appeal claim determinations that are made by the MACs. The beneficiary or their representative may request an appeal on any service processed for them, but providers and suppliers may appeal services for which they accept assignment. For unassigned claims, though, providers and suppliers may act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement. In addition, a provider or supplier may request a redetermination on an unassigned claim for a couple of reasons. If the service was denied as not medically reasonable and necessary, or when the provider or supplier billed in excess of the limiting charge. Now, the first level of appeal is the redetermination, and it is the only level of appeal rendered by the MAC. Time frames apply to each level when submitting an appeal, and additionally, there's a minimum amount in controversy that applies to levels 3 and 5. You can combine like denials or similar denials in order to reach the AIC. I've included here now on this slide a couple of resources for you specific to appeals. The how to appeal a claim determination, the first bulleted link here, and you'll see that I've embedded links for all of these resources within this particular presentation. So if you've downloaded it, you can simply hover over, click on the link, and open the resource. How to appeal a claim determination is the resource available on the WPS website. Has a lot of great information, tells you who can request the appeal, who has the right to request the appeal, and so on and so forth. The second bullet there, the CMS fee-for-service appeals process flowchart is just one of my personal favorites that I like to share with providers when I talk about appeals. If you look closely at this particular flowchart, and I just took a copy of it and pasted it here onto the slide, you will see all 5 levels of appeal on here for original Medicare Parts A and Part B. The standard process is on the left. The expedited process, which is for some Part A only, is on the right. You can see where the initial determination is made. The first level of appeal is the redetermination done by the MAC. You have 120 days to file that. You have 60 days, or the MAC has 60 days to make their decision. Then you have 180 days from the remit notice for the MAC redetermination to file the second level of appeal, which is the Qualified Independent Contractor Reconsideration, or the QUIC. And the QUIC has a 60-day time limit to make their decision, and so on and so forth. You see the third level appeal here. Appeal is the Office of Medicare Hearings and Appeals. Some people call it the ALJ hearing, Administrative Law Judge hearing. That amount in controversy you'll see there is greater than or equal to $190. Fourth level of appeal is the Medicare Appeals Council, and again, you have so many days to file it, and those contractors have so many days to make their decision. That's all here on this flow chart. That's why I like this. One thing I do want to caution you about, though, before moving on, I will mention, though, that the AIC for the 5th level of appeal in federal district court is greater than or equal to $1,900. I do want to mention to you that this document is updated annually, so if you're looking for it in January, make sure you look to the bottom of this document to see what the date is. This says here, the final sentence here says, this chart reflects the amounts for calendar year 2025, so keep that in mind. All right, the next portion then of today's webinar focuses on that data. Just as I advertised, I told you that I'm going to reveal the most common rejections and denials for colorectal surgery specialists based on the data for WPS claims. When I pulled the data or looked for the data, I used a tool that we call the data dashboard in order to get that information and share it with you. The data dashboard is an interactive tool designed by our data analysts in our Insight department. Insight is the name of the unit at WPS that's responsible for mining data and data trends, among other tasks and responsibilities. And they built this dashboard so people like Jennifer and I can pull this data. I mean, just at a touch of a button, we can pull the data. It's amazing how quick all of this information comes back. So let's take a look at ways to view the data. There's, different ways we can view the data. We can, in an instant, view rejections or denials. We can drill down by state. In even county, we can drill down by specialty, by CPT or HCPCS code. We can use the dashboard even to view trending, and trending starts or alerts us rather to those spikes or those increases that would require education or immediate attention. So when the data unit built this, they took input from people like provider outreach and education and other units as well that use this type of dashboard. But they put drop-down menu items in it so that we can select those they call them data slicers. So we could select the criteria or filter out the claims that we want to review. So for today, what I'm sharing is all Specialty 28 colorectal surgery claims submitted for Jurisdiction 5 and Jurisdiction 8. And of course, that means Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. While the dashboard does allow us to drill down by a specific state or states, I pulled data for our entire jurisdiction. Now, for those of you that are wondering what a specialty code is, I mentioned it a couple of times. Specialty 28. It's a 2-digit code that's assigned to WPS providers when they enroll. During enrollment, providers self-designate a specialty, while a provider can designate a secondary specialty. It is only the primary specialty, the one designated by the provider himself or herself, that is used during initial claim processing. Those edits and audits built into our system will look only at that primary specialty code when we're processing claim. Now, there are some situations where a provider will request an appeal and stipulate their secondary specialty in order for us to make payment. So Specialty 28 is colorectal surgery claims. I pulled claim submission dates November 1 through January 31 of 2025. The data was last refreshed on February 10th of 20. That should be 2025, folks. Another typo. I apologize for that. 2024 should read 2025. So what this means is if you submitted a claim for those submission date, or if you submitted a claim between November 24 and January of 25, we pulled the data on February 10th. So anything that was submitted into the House, we pulled on February 10th. Now, if you submitted anything after that, of course, it wouldn't be included in this data that I looked at for today's webinar, the data I'm sharing. So here then are those most common rejection reasons for your specialty. And I think it's kind of interesting. Let me just go back here. I think it's kind of interesting that sometimes the data shows us not what we think are the reasons for rejections and denials, but something more very common and more simple in nature. For example, rather, the top rejection for your specialty is invalid or missing modifier, 34 claims or claim lines. Very similar. The second one there, missing procedure modifier, 17. Well, what do you need to do? These are rejected claims. You need to first of all look to see if there was a modifier required. And did you put it on the claim? Did you put it in the right place? Did you transpose it when you added it? Is it a correct modifier? Is it invalid? Is it missing altogether? So these are really what I think would be simple fixes once you know and you can realize or recognize the types of rejections that are happening to your claims. Next is missing, incomplete, invalid name, strength, or dosage of drug. 14 rejections. I caught myself there. What happens here is very often when a claim reports a drug that's being billed, the information that's needed in item 19 or the electronic equivalent is missing. So you need to check back to see what it is you need to report. You know, do you need that strength or dosage of the drug, the name of it, and so on. Next, facility, lab name, and address or PIN is missing. On the claim form, there are required elements, some of which require you to put the address of the facility where the service is being rendered. If it's not there, your claim will reject. More, missing, incomplete, invalid, billing provider primary identifier. Was it keyed right? Was it there? Was it in the right place? Things to ask. Claims should be sent to United Mine Workers of America for processing. Not American, it's America for processing. This happens when the Medicare beneficiary is a retired co-worker. In that case, the claim needs to go to United Mine Workers of America for processing, not to WPS. And I'll show you a resource later where you can find where to submit those. Patient, insured name, and Medicare beneficiary identifier do not match. If you look at the Medicare card, if there's a middle initial, you need to report it that way on the claim. Um, and that's typically the reason why these rejections are occurring, is because that middle initial is missing. So I thought it would be interesting not only to tell you the reasons why your claims are rejecting specialty 28 claims, but to show you the top codes based on the data, actual claim data. 87 claim lines denied, 45,385. Number one reason, invalid or missing modifier. These are going to be reflective of what you saw on the last two slides here, but some add just a little bit more information depending on the code. Claims should be sent to United Mine Workers, facility name and address missing. That is the reason why that code is rejecting. It's not because it was a wrong diagnosis. Those are the top reasons. Diagnosis would be a denial though. G0105, 24 claim lines rejected, missing modifier, invalid, missing modifier, incomplete, invalid, billing provider number. Top reasons, folks, based on the data, why that code is denying is because this information is missing from the claim. Same with facility lab name and address. 45,380, 18 claim rejections within the time period that I looked at data. Same reasons here. There's a new one. Place of service conflicts with procedure code. For some CPT codes, Medicare will allow those services billed only in certain places of service. So this would be a situation where, based on that CPT code, that place of service conflicts. What you need to do here is, check to see if it was keyed correctly. Check records, make certain you're reporting the correct place of service. Now, sometimes the claims will reject appropriately because you can't provide that particular service in that place of service. On the other hand, it may be a situation where services were just reported incorrectly. You need to fix it and resubmit it. A couple more. G0121, same thing here. Modifier missing, missing billing provider identifier, or the information received was not complete. 45378, 15 claim lines, invalid or missing provider or modifier, primary payment information was not reported. That's an MSP reason. So that will be related to rejection for a Medicare secondary payer situation. So if your claim rejects for this reason, you're going to want to go back and make certain that you filled in this information on the claim, what the primary payer paid for the service that you're submitting to Medicare for secondary payment. There's another one of those: place of service conflicts with procedure code. Back to the G0121, something I didn't mention earlier. I said the information received was incomplete. We have, and I'll show you it in just a minute when I get to the resources. CMS makes available in their internet-only manuals the claim form instructions. They have both the electronic format and the paper format. So you will need to take a look at your claim to see what it is that's missing. I'm going to show you a crosswalk in a little bit that tells you if you put it in this place on a paper claim, where do you put it on the electronic claim? I also want to tell you that all of these claim form instructions, both the electronic and the paper claim form instructions, will tell you whether an element on that claim is required or if it's situational, contingent upon something else that's reported on the claim. Now, I mentioned to you how we look at trending. Those examples we can look at the data and we can quickly see, based on that dashboard built by Insight, the trending for a particular reason or code. And in this case, what I looked at was missing procedure modifier, because that one seemed to pop up a lot for your specialty. We can see a claim line or claim count for the current 3 months. compare it to the prior 3 months. That report tells you the claim increase and then puts it into a percentage. It also shows us a red arrow or a green arrow. Green arrow would be going down, of course, and the red arrow going up. But this gives us a really quick look at something that we might want to consider for a little bit more in-depth education, kind of like some of those situations that you wrote when you registered that you wanted to hear about, those topics that we're not covering today in this webinar, because today we are really talking about data and reasons for rejections and denials. But these would be something, maybe we'd write a news item. Maybe we'd just make a short little YouTube video, or maybe we need 60 minutes of a webinar to talk about these. So all kinds of things to consider. Here then are common denial reasons for your specialty claim lines. Oh, look at that first one. Look at the third one. Duplicates. I'll tell you, folks, I have been in Medicare for quite some time, and this is something that we have long been educating about, and we haven't been able to put a stop to it. 98 and 73. The claim counts for the claims that I looked at for your specialty were relatively small. But for some specialties, these numbers are up into the 19,000 claim lines were denied as a duplicate in 3 months. So while it's not as many claims for your specialty, overall, when you think about all of the specialties, gosh, there must be 90 or 80 duplicate charges, and duplicate charges of claims now being processed are really kind of kicking us, folks. If you could put $1 on every claim you submit to Medicare, think about all of those that you're submitting that are duplicates, needlessly submitted. If you use a billing service and they bill every 30 days, tell them to stop. If you do that, you need to stop. It is considered abusive to submit duplicate claims or charges to Medicare. Once educated, abuse can become fraudulent. So don't let yourself ever be in that situation. Take the needed actions within your office or your organization to stop submitting these duplicate charges to the best of your abilities. Next, Medicare will not pay for this service for this condition, 89. Now that, folks, would be a denial that's telling me, or should be telling you, that we're not going to pay for this code for this ICD-10 code, this diagnosis code. So a couple of things you can do here. Make sure everything's coded correctly, first and foremost. And the other thing that you could do is check to see if there's a policy. Out on the WPS website, I'm going to show you right now because I don't want to forget to show you the easy way to do this. Hang on just a minute. I'm moving some screens around here. Hang in there with me, folks. On our website, this is our homepage of our website, wpsgha.com. There is a code lookup tool on the front page. By using this tool, you can enter in codes, titles, or definitions to see if there is a local coverage determination or national coverage determination or local coverage determination article with that particular code or title or word, definition, term in it. Now remember though that if it is a code you're placing in here, you're going to find it in an article, not in a local coverage determination, because CMS requires that the MACs all not include coding information in their local coverage determinations themselves. It would be the companion article that has codes in it. So I just wanted to point that out to you. And of course, if you're looking on our topic center, we also have our policies portion or topic center, if you will, that you can click on and find more information. All right, so that is the code lookup. Pre and post-op care included in surgery. You may not bill the patient. This could happen for a few reasons. Obviously, Pre and post-op care is included in reimbursement for surgery, so Medicare's not going to allow those E&M services that happen within the global surgery period. Out on our YouTube channel, we have multiple recordings of education that talk about global surgery. So those would be really great resources for you. CMS's relative value file provides for you the pre and post-op days for each CPT code or HCPCS code in the relative value file. So you could look there to see, did you bill the service within the global surgery period and so on and so forth. Another thing that you'll want to check with this denial is you're going to need to check um, modifiers for global surgery. Maybe you didn't key the right modifier. You put the wrong modifier on the claim. Out in the topic center, we have claims. I'm going to click there. I'm just going to choose Part B. Part BJ8, just because it was the closest one. If you scroll down this list on our claims topic center, you'll find modifier and more modifiers. There's a lot of global surgery modifier information out here. This is also helpful because, sorry about that, background noise, folks. Hang on just a sec. There are some children playing outside the door, and somebody thought that they were making too much noise, apparently. Getting down here, moving along. Here, surgery modifiers. This has many of those global surgery modifiers, right? So in addition, a lot of the other top rejections and denials, or top rejections that I talked about, not denials, had to do with missing modifiers and such. So if you need information about use of modifiers, it's out here on our modifiers page. All right, moving that back over. Okay, collection of fee-for-service during periods of managed care. I have to laugh about this one, folks. Remember, I told you we get a lot of calls from folks or providers that say, this is really cryptic. I'm not really sure what it means. Well, what this really means is that this claim is being denied because the patient is managed care, which means they have Part C. Excuse me, so WPS would not process a claim for a Medicare Advantage or Part C patient, eligible patient, someone who's elected Part C. We are traditional Medicare or original Medicare. So that situation would be a denial based on that. All right, here comes the codes. 99024, separate payment not made for this service, do not bill a patient. Certain codes are inclusive, they're bundled, we don't make a separate payment. These are Medicare rules, and we would expect to see these at times, but you have to report them. So this would be something when we looked at trending that would be non-significant because we know that those types of codes are going to be reported. Pre and post-op included in surgery 99232, that follow-up visit, collection of fee-for-service during periods of managed care. And look at this, duplicate being billed. What happens here, I think, is that it doesn't get paid the first time, so it just gets resubmitted. Don't do that. It's a duplicate. If we deny it the first time, it's going to be denied the second time. Yeah. 99213, pre-post-op care included in surgery. There's that duplicate. Here, one visit per doctor per day. Do not bill the patient. So in this case, we know that someone else had to have billed a visit on the same day. Collection of fee-for-service during periods of managed care. 45385, that's surgery code. Medicare will not pay for this service for this condition. So this one would be a situation where you'd want to make certain that everything was keyed correctly and check that policy. Check a policy or look for a policy to see if there's a policy that includes that particular CPT code, and then check out the payable diagnosis codes. Duplicate claim must, here's something new, claim must be sent to employer group health plan. What this means, folks, is that there is insurance that's primary to Medicare. So we've denied that particular service because it needs to be sent to the employer group health plan first. 45,330, Medicare will not pay for this service for this condition, so that's a diagnosis denial. Information does not support the need for this service. That could be related to diagnosis as well. And pre-post-op care included in surgery. You may not bill the patient. That one, folks, I'm going to have to look up because this is a surgery code. I apologize for that. Something doesn't look like, doesn't look correct with that. I'm sorry. Typically, pre-post-op care included in surgery would be an E&M code, and so I'm questioning myself why that surgery code shows that denial. So, folks, I'm going to follow up with you after this webinar and make certain you have the correct denial reasons for that code, because that one just doesn't seem right to me now that I'm looking at it. All right, and here's that trending example, specialty 28 denials. This one is one I wanted to pull out because this is happening a lot. In fact, we're doing special education on it. Time limit for filing your claim has expired, no appeal right. 18 the current 3 months, only 2 the last 3. There's a 16 claim increase, that's 800% change. That, folks, is why we are doing education on timely claim filing. And I do want to show you, and this is listed in your resources later in your presentation materials. I just did a search of timely in the search box, and the first result that comes back is timely filing of claims. This is a great article. Excuse me for a moment. Thanks for standing by. I apologize for that interruption. Here is a really great article that our team has put together on timely filing of claims. It explains to you that claims that are denied based on timely filing do not have appeal rights. This is that exception that I talked about earlier. Most claims or most remittance advice when there's a denial is going to have that MA01 on it. You will not find an MA01 on a claim that's denied for timely filing because there are no appeal rights. Now, there are some situations where providers can ask Medicare for a waiver of that timely filing, and this explains how to file that waiver to extend that timely filing limit. You'll notice that I'm on the J8 MAC website right now. You can see it's blue up here in the underneath the search box, J8 MAC Part B. If you want to pop over to J5 MAC Part B, you can simply do that by clicking on J5 MAC Part B. Then you'll have the mailing addresses for our J5 states. But I do want to point out that CMS specifically in their internet-only manual publication 100-04, that's the Medicare Claims Processing Manual, in Chapter 34 says this right here. Third-party payer error in making a primary payment determination does not constitute good cause for the purposes of reopening an initial determination or redetermination when Medicare processed the claim in accordance with the information in its system records on the claim form. All right, what this is basically telling you that if that other payer paid that claim 7 years ago and comes back knocking on your door to say, we weren't primary, Medicare was, we want our money back, this is CMS saying it's too late. Medicare's not going to pay. We get a lot of questions about that, but if you look in that portion of the internet-only manual, you will see CMS's specific instructions that says, you know, it's not a good enough reason. Unfortunately, we hear a lot of providers that have been stuck in exactly that situation, but WPS cannot do anything about that. All right, so modifier issue fixes. Now, I talked about some of these as I went through, and I'm going to go through these pretty quick. We got a lot of information that I want to share with you yet. I talked about this earlier. If there's a modifier that's required, make sure that it was there, or make sure you're putting it on the claim when it's required. Make sure your modifier matches the procedure code. It goes along with that procedure code. Some modifiers cannot be used with an E&M code. Uh, just as an example. Um, Also, make sure your modifier was valid for the date of service. Sometimes CMS creates new modifiers. Make certain that your date of service is one for which that modifier can be paid or billed, reported. I do want to show you that, going to it out here. What I talked about earlier, it's the crosswalk. I'm going to go back to our home page. And this link is in your present. It's in the resources, but I want to show you this just so you can visualize it because it's important. On the home page, under quick links is EDI, which is Electronic Data Interchange. We have a separate web page for EDI. If you scroll down, you will see Medicare, TRICARE, and EDI for our commercial business. Of course, it's Medicare. We want to choose Medicare. And if you scroll down this page, Medicare EDI, I want to point out those companion guides that I talked about earlier when you're submitting your claim. What are the required data elements? But right here, this crosswalk walks you from the paper claim to the electronic claim. Let me try to make it a little bigger here for you. Okay, let's see what I can do here. Okay, I want to show you. Oh, I went too far. Okay, so for example, this tells you that about the claim forms. Call us at these numbers if you have questions regarding this information. But it walks you from the CMS 1500 to the 5010 electronic claim. So if it goes in item number 1 on the paper claim form, where does it go then on the electronic format? Okay, this tells you the data element description. It tells you the requirements for the version 5010, which is the electronic claim. And you'll notice this status column here, second from the right, status. See all these R's, there's some S's. This is what I kind of talked about earlier. Any data element that is needed in order to process a claim, R means it's required, and S means it's situational. So this will help you know whether you need to complete that portion of the claim. Okay, I'm just going to scroll down here a little bit. Item 19 on a paper claim form can be used for a lot of information, so you'll see several listings for it, depending on what it is you need to see to place on the claim, so on and so forth. So some great information. It tells you, if something's missing from your claim or the information was not provided, look here. Make sure that you have included all the information on your claim that's required. Place of service. That was some of the problems that we saw, or rejections. Make sure you keyed it correctly, that the place of service matches the procedure code. For some services, surgery services I can think of, they're obviously not going to be done in an office. So that just, it doesn't make sense. It's illogical. It's not right. Your claim is going to reject. Place of service valid for date of service. It's another thing to check on. Some places of services are added by CMS. They're new. They're not valid 1 year as opposed to the next. Patient eligibility fixes really wasn't too much of a big issue for your specialty, except for some of your claims should have been submitted to the United Mine Workers of America rather than to WPS. And make sure that that patient name and MBI match exactly. We also get a lot of claims that should be submitted to the Railroad Retirement Board or to Medicare Part C, so I added those as well. Verify provider numbers. Make sure that you're entering it, making sure that there's no keying errors. Maybe there's something in the provider enrollment records you need to validate. Give them a call. Rendering providers associated with the billing provider, and make sure that your ordering provider information is entered on the claim if whatever you're billing for requires an ordering provider. Here's the dupes. Don't just automatically resubmit prior to establishing the status of that particular item or service. Make sure that you're appropriately billing. Make sure that modifiers are being submitted accurately. Sometimes this can cause, or these can be problematic because you're not reporting modifiers, is what I should say. Repeat procedures, for example, and something will deny as a duplicate instead. So just some things to think about. MSP denials, verify whether the patient has insurance that is primary to Medicare, and make sure that you're submitting all that information on the claim then that is required and not situational in those item numbers where MSP information is gathered. I know that item number 11 is where you say, is there another insurance primary to Medicare? Right here, insurance plan name or program name is here. Make sure that when these are required or situational, that you're adequately reporting that information on your claims. I think one of the reasons here too was that you didn't, this specialty didn't have the amount that was paid by the other plan. So that would be tied to the MSP too. Here are some MSP resources. We have a lot of them, including YouTube videos. We have an MSP playlist on our YouTube channel. I'm not going to go through each and every one of these because they really truly are just a lot of resources for you, really kind of coming back to how do you fix it, how do you avoid it. E&M denials, verify new patient status versus established patient. We didn't see a whole lot of those types of denials in your specialty, but we did see the global care period issues. Sorry. So I just want you to know that there are some great resources available. E&M, we had, the last I looked, I think over 45 YouTube videos out on our YouTube channel that were specific to evaluation and management services. CMS has published an evaluation and management services guide. That's our go-to resource when we do education for E&M. CMS has made it very, very clear in their internet-only manuals that we are not to reinvent the wheel. If they have education available, we are to use it. So we use this evaluation and management services guide often, and it does talk about global surgery in that. Avoid medical necessity denials. This is what I talked to about earlier. Check those national coverage determinations, local coverage determinations, and also those local coverage articles, of course, because they may include the procedure and diagnosis code. This, of course, would be for those denials that pertain to this service isn't covered for this diagnosis or this condition. Timely filing. I already showed you here where you can find the information on our website. It was this, referred to timely filing of claims. Right here's the link to that resource that I showed you. That common reason, of course, is that primary insurer paid in full and they came back later, took the money back. A good recommendation for those situations, even when another insurance pays in full, is to get that claim submitted so that you do have a timely submitted claim to Medicare, even if you think someone else is going to pay it. Might not be a bad idea to submit a claim anyway. At least then you had one that was submitted timely. More resources and tools, lots and lots of them. This is that internet-only manual that I talked about. This is the paper claim form processing and the crosswalk to the electronic claim. The IVR is a good tool to use to find claim status, check to see if something's still being processed. This is 24 hours a day, 7 days a week. Of course, there is limited functionality outside of normal business hours. This is the tool where you use your telephone keypad or your voice. We do have an IVR operating guide that provides instructions. We also have that secure SNAP tool available for registered users. This is where you can check eligibility, claim status, claim details, and claim actions. Again, 24/7, limited functionality outside business hours. We offer that portal user manual, and I'm not certain that all of you are aware of this, but on each and every single page of our website, we have this on our home page here. It's the portal user manual right here, a link to that. This, of course, would be where you log in, and this is where you can register. Also on the very bottom of our any page on our website, right here is a link to our portal user manual, illustrations and instructions on all the functionalities of SNAP. All right, so lots of great information there. We have this resource on our website. It kind of covers a lot of the information that I've talked about already. How to correct a rejected claim. The nice thing about this particular tool, I'm going to pull it up here real quick because it'll be an example for the next one too. What we have done here is we have listed by reason codes and remark codes what you can do to fix that claim. Okay. Right, so they're listed by reason and remark codes. I talked about those earlier. The Washington Publishing Company writes those, not WPS. And here then is the Common Claim Denials resource we have, which really does the same things. It takes those reason and remark codes, but only this time we categorized them. We have reason and remark codes for bundling. We have reason and remark codes for duplicates, global surgery, so on and so forth. So out on the website, look for those codes in those categories to get more help with denials. More recent, whoa, sorry about that, folks. Um, Here is the WPS website. Live events is for future presentations. Encore presentations are a recording. I've got some information available here. If you're billing NOC codes, I did see, and not one of the most common rejections or denials, but I did see a fairly good use of NOC codes for specialty 28. This tells you what you need to put where on the claim to describe what it is you're billing. YouTube channel, E&M, remember, over 47 or over 45 videos. We got some good stuff out there too for Medicare Advantage plans. These are we get a lot of questions about MA, and we get a lot of claims for MA, and we can't process those, and we can't answer questions for those because we are not the plan. They are different. We are traditional original Medicare. All right, more checking eligibility. We didn't have a lot of eligibility issues here, but just with those United Mine workers. The contractor directory interactive map is a map on CMS's website where you can click on any state and it will give you the names of all the contractors so you know who to submit your claim to. The place of service code set. We had some place of service rejections or denials that I talked about today. The place of service code set I've included here for you too. Coverage database. This tells you how to look up, and this is linked here, how to look for a local coverage determination or a policy article or a national article. And this brings us to questions and answers, and I right now have 3 minutes, so I am not going to open for questions and answers live, but I will tell you how you can submit them to us. But first of all, I want to talk a little bit about the Certificate of Achievement because we get a lot of post-webinar communication from people looking for their Certificate of Achievement. What's going to happen is that in a few minutes you're going to receive an automated email. It's going to come from WebEx. That's our webinar platform. It's going to thank you for attending. Don't delete that without reading it or keeping it if you're looking for continuing education units or CEUs. This email contains your CEU or your Certificate of Achievement rather. The email is going to look like what you see on your screen. It's going to have your name, contact hours, where you need to turn it, or if you, I should say, not where, if you need to turn it in for continuing education units. So for example, AAPC or a national, society or organization. If you don't see that email, check your spam or your junk mail. Sometimes it delivers there. If you find it there, make sure to add the WebEx email address on this slide right at the bottom to your Safe Center list, because if you attend future events, the same thing will happen. Now, here's the caveat though. If you join by phone only today, you will not receive that automated email response from WebEx because they won't have your email address to thank you for attending. If you need a Certificate of Achievement, send an email to our education mailbox. That email address is also on the bottom of this slide. Include today's date, the name of the webinar, and the telephone number that you called in from. After we verify your participation, we will send you that Certificate of Achievement that you can turn in for your CEUs. Here, folks, is where you can send those follow-up questions. If you think of any presentation related questions, and again, presentation related, I can answer questions about what I advertised I was going to talk about today. I can't talk about what I want to say, documentation. Some of those questions were things that were really outside of what this webinar was planned for today. Certainly good suggestions and such, but put those on that survey that I'm going to ask you to complete in just a couple of minutes here, and we'll consider those for future education. If you submitted a question in the chat and we didn't get to it because this went a little long today, send them to our education mailbox. The email address is here. The subject line is the name of today's event. And remember that any claim-specific questions do need to go to customer service. And here then is the link to that survey. Tell us what you liked, what we could do better. Suggest those topics for future education. Your feedback really is invaluable. It ensures that our education is timely and effective. The survey is so important, we're going to give you another chance to complete it. When you exit this webinar, you'll be directed to a CMS Qualtrics page for the survey. It's going to look like that picture you see at the bottom with the yellow triangle at the top. It is legit, but if you've already completed the survey, you would not need to complete it, of course, but if you didn't, we'd love to hear from you, and please use that last opportunity to do so, or use the link within the electronic download of the presentation materials. On behalf of myself and Jennifer and the entire Provider Outreach and Education team, I do want to thank you for your participation. We look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everybody. Have a great day.